Okay, thank you again, everyone. So I'm here to introduce Dr. Susie Liu, if you don't already know her. She's a professor of medicine and the director of the clinical services. She's also medical director for peritoneal dialysis at the DaVita Clinic and K Street. Dr. Liu received her BS from Brooklyn College and her MD from SUNY Downstate Medical Center. She completed her medical education in internal medicine at Brookdale Medical Center and her fellowship in nephrology at Mount Sinai Medical Center. Dr. Liu has been recognized as a top doctor from the Washingtonian magazine since 2004. Her clinical interests include peritoneal dialysis, where she cares for the largest number of peritoneal dialysis patients in the DC area. She's also interested in pregnancy-related kidney diseases and hypertension, as well as chronic kidney disease. Dr. Liu partners with industries to evaluate the safety and clinical utility of new therapies and exploring new indications for existing drugs. She has served as a grant reviewer for the National Institute of Health, as well as a site principal investigator for a multi-center pharmaceutical studies in the areas of anemia, iron therapy, chronic kidney disease, and nutritional supplement. Her expertise is sought by scientific journals in the area of peritoneal dialysis. And finally, she was also involved in several trials evaluating safety and efficacy of new dialyzers, dialyzer reuse, and new dialysis techniques. So today she's going to speak about telehealth and with a specialization in end-stage kidney disease. I'm going to send around a sign-in sheet and some bakalava from Michigan, Dearborn, Michigan for everyone.
All right. Well, thank you very much for the introduction, and thank you so much for inviting me to be part of this journal club that you have. It's an awesome thing that you do to share literature and learn more publications and how to do research. So today's paper is entitled Telehealth in the United States for Patients with End-Stage Kidney Disease, Its Utilization and Impact on Social, Economic, and Health Outcomes. And my co-authors are Neil Sika, who is a physician in the emergency department here, and Kevin Edson, who is at the University of Texas section. So I have no disclosures, and all the images are taken from me. What I do is take care of patients who have kidney failure, meaning that their kidneys don't work anymore and they need life-sustaining hemodialysis or some sort of dialysis. And one of the forms of dialysis that we do is in-center hemodialysis. And so here is a patient getting dialysis. He comes 3 times a week. They sit in the chair for 3 to 4 hours. There's 2 needles that are put in, and blood is taken out through 1 needle, blood is cleaned, and it's returned to the patient. We can't take all their blood out all at once and clean it, because that could be done in 10 minutes. So that's why it takes 3 to 4 hours. Each patient has a nurse assigned to this patient. There's a dietitian, social worker, and a doctor. And in this dialysis unit, there is a medical director that oversees the whole unit. And the doctor is responsible for writing at least 1 note per month, which is the comprehensive note that has like symptoms and objective findings, labs, and assessment and plan. And the other 3 could be, he's doing okay, or his blood pressure is a little bit high, it just needs to be tweaked, okay? And that's the life of a dialysis patient. The doctors, actually, the nephrologists, go to the dialysis unit to see the patient. It's not like the patient comes to the clinic. I'll see. So let me just backtrack that this paper that we're reviewing today is a review paper. So I'm going to reformulate it as if it was a research project where we do introduction, our background, methods, results, and then the discussion. Okay. So this is the background information, is the dialysis space that I spend a lot of time in. The other forms of dialysis is home peritoneal dialysis. This is a treatment in which a tube is placed into the peritoneal space and fluid is put in there several times a day, or a machine can do it over a couple of hours. We call those exchanges. And the waste product in the body diffuse into this fluid, and then that's how the waste gets removed. So when comparing peritoneal dialysis to hemodialysis, this is a slower, gentler form because it's not like this machine cleaning it in 4 hours. And so patients have less symptoms, but they have to do it every single day because the clearance is just so much slower than hemodialysis. But overall, it's comparable. They say it's the people who are on this, and we actually recommend patients to go on this treatment, is because the kidney function gets preserved, meaning that they still continue to make urine even though the kidney's not working. Whereas those patients who are on hemodialysis, within a month or two of starting dialysis, they make almost no urine at all. And we like patients to still make urine. There's waste that's removed, volume as well. This system is a lot more flexible because it's done in the home. They don't have to go to the dialysis unit 3 times a week. They schedule it whenever is convenient for them. So usually it's at night. They put themselves on before they go to bed. The machine does all the work. And then in the morning they wake up, they just disconnect and then they could go about their business. Usually this is good for, I guess, moms who have children that they have to take care of. So they don't have to like find a babysitter to take care of their children. This is good for students because they don't have to miss time away from school. Business people like because they can, do it at night and not have to take time. I guess the bad thing about this is that we deliver supplies to the house, and usually there's like 40 boxes of solution that is delivered every month, and that takes up a lot of space, and not everybody has that space in their house to do this. We can also train our patients to do home hemodialysis. So it's the same thing as the dialysis in center, but we do it for a shorter period of time. Usually it's 2 to 3 hours each time they do it, but it's for 5 times a week. And actually, Dr. Yang, who is one of my colleagues sitting over there, is the director of the home hemodialysis in our dialysis unit. And the patients learn to cannulate their access. They learn to set up the machine, and they do it on their own. You have to have electricity. The solutions are delivered to the house, and we make it work. So that's the patient population. Let me tell you a little bit about this end-stage renal disease. So when dialysis first began, there were just a few centers that were doing it, and there were only a few machines. And it was very expensive to run these dialysis sessions. So there were committees that would decide who would be eligible to go on dialysis and who would not. So this was called the Committee of Gods. And so like a CEO who was productive would, of course, go on dialysis because he had something to contribute to society. But somebody who was retired or someone who was homeless, didn't have extended family, they would say, you're not contributing to society and you're just, using a lot of resources. So we won't give you dialysis. And so that wasn't a fair way of allotting dialysis. And so there was a patient who went to Congress and he performed dialysis on the floor of Congress. And that was in 1972. And the House and Senate saw this person being dialyzed and said, this is a life-saving procedure, not give it to everybody. And so they passed a bill and President Nixon signed it that said that people who put money into the Social Security system, so they are eligible for Social Security when they reach 65, no matter what their age is. And if they put in a certain number of months, it's like 40 months that they put in money into the Social Security, they would be eligible to get Medicare at whatever age, and the Medicare will pay for the dialysis. And so 90+% of our patients are on Medicare, and that's how their dialysis gets paid. Okay, because Medicare is paying for this, they control everything. So Congress passes these laws that said, if we're giving you this much amount of money to perform dialysis, we want to know what you're doing. So every month you need to send in the lab results. We want to make sure that the patients are being treated equitably. So therefore, we want you to make sure they're getting medicines to treat their anemia. We want to make sure that you're getting medicine to treat their bone disease. And they dictate what patients receive. And that's why there's a nurse, a social worker, and a dietitian that sees the patient, because the federal government says this is what you need. Okay? We also will provide transportation to make sure your patients come to the dialysis unit, because if they can't get to the dialysis unit, they will not get their dialysis, and therefore, they'll get sick. And so we're just spinning our wheels. So as of 2024, the end-stage renal disease account for about 1% of the Medicare beneficiary, but they consume 7% of the Medicare. Okay, so this is the cost to perform dialysis in the in-center, and for anything that happens in the hospital if they get admitted for complications. Okay, so here's a question to stimulate discussion. What health services research problem is being addressed in this article? So I think at this point, this is where people volunteer information.
So can telehealth be used to improve access to dialysis care?
Right, okay, because the cost of dialysis is so high that, is there a way that we can use telehealth to perhaps improve that? Okay. How about ways to cut the budget down so they're not consuming 7%? Is there something else we can do? Yeah. Can we use telehealth for them to see other clinicians, like the endocrinologist if they have diabetes, or a cardiologist, or whatever? So, think outside of just dialysis. Once they have the equipment to perform telehealth, and probably do it with other clinicians. Okay, so telehealth is a very broad term. It also implies remote monitoring. So just like people with diabetes, now we have continuous glucose monitoring. Can we monitor these patients at home? Is there a way that they could check their blood pressure and have that information put in? So this way they don't come to the dialysis unit with high blood pressure, or go to the emergency department with high blood pressure. So there are ways to, use this telehealth. Okay. And then I noticed that you all come from different parts of the medical center. What is the problem? Why is this problem important to the members of the audience? So how will this, help you?
One, if we can decrease Medicare spending, it helps us all.
Right.
But two, I think the broader, it's like your point of like, what other aspects of medicine can we apply telehealth to improve access and equity in our work?
Okay, so we're interested in patient outcome. We want them to have the best outcome. So we will do a little bit of something for our patients, but we also want to decrease the cost for taking care of these patients. Okay, good. All right. So the telehealth that we do, the goal is to improve care. We want to make sure that imposing telehealth on these patients will have long-term safety issues as improvement. Of course, decrease costs, and we want to decrease patient hospitalization, length of stay, and ED visits. And of course, we want to make sure that the patient is satisfied with the care, because there's no point in imposing telehealth on them if they're not getting the care that they feel they need or deserve. Okay, so the way I look at telehealth is before COVID, during COVID, and post-COVID. This figure comes from the paper. So forget everything around and just look at the first box at the bottom. So before COVID, telehealth was very restricted. It was restricted really to areas, I call it rural area, where there aren't a lot of doctors to provide services. It was the patient had to be in a either a doctor's office or a federal qualified health center or a hospital. The doctor had to be at the hospital or the health center. And so there was still, the patient had to go somewhere to be seen, and only certain clinicians could perform telehealth. And now you can always pick up the phone and talk to a patient, you could do video, but you won't get reimbursed. So only if they were in these certain locations and qualify would they get reimbursed, okay? It's all about reimbursement. So that's why this is before COVID. Then, and there weren't too many platforms that were available. They had to be, HIPAA compliant. And so it was a whole lot to do, and not many people really used it. And for example, in the dialysis population, I mentioned that usually you like 4 visits per month, so 1 visit per week just to keep tabs on the patient. But the patients who lived in rural areas, and there's like a dialysis unit that serviced, a 100-mile radius, the doctor usually just would go once a month because there's no way to go there, to travel 100 miles to go see a few patients once a week. It's just not cost effective. And so they didn't get a lot of care. But if they were able to do telehealth, then they can actually, the nurse can actually sort of dial up the doctor and says, we have a couple of patients here that would like to talk to you, and do it. But unfortunately, it said very clearly in the regs that dialysis unit was not a place that you could do telemedicine. So it wasn't done. So it was very limiting, okay? So then in 2018, there was the Bipartisan Budget Act of 2018 that allowed home dialysis patients, so that would be home peritoneal dialysis or home hemodialysis patients, to be seen at home once a month, because their visits were only once a month anyway. So for the first time, home became an originating site, so the patient could be there. The doctor still had to be in a hospital or the dialysis unit or the office. They couldn't do it from home. But there was no geographic restriction. So that means the patient could be living in the city or in a rural area. So it was anybody who was on home dialysis. So this was a big plus. So this is the doctor visit. The patient still had to get monthly blood drawn, because that was a requirement of a dialysis patient, is to have monthly labs. So arrangements had to be made for them to go to some place to get the labs done. A lot of times they would come into the dialysis unit to get the labs done, but then do the doctor visit by telehealth. And very specifically, they said that if it's a new patient, they had to see the doctor 3 times, 3 monthly visits to establish care. And then after that, every quarter, that means every 3 months, 2 of the visits could be done by telehealth. 1 of them still, the patient had to come in. So it wasn't, like all telehealth. There was some guardrails to make sure that they were still coming in to be seen. And that law was passed, and that law still exists, and that will go on unless it gets changed, okay? So then COVID comes along, okay? And there was social distancing, and there were these waivers, public health emergency waivers, that were passed that allowed patients to be at home, the doctor could be home, the patient could be in the dialysis unit. It was wherever the patient was fine, but not at work. It had to be home or the dialysis unit or in a doctor's office. It could be, there was no geographic restriction. And the platforms, it didn't have to be HIPAA compliant, because not everybody was geared up for it. So you could have actually done telemedicine using FaceTime or Zoom or Skype, whatever it was. But the key was to have the patient connect with the doctor or the team. So in fact, it happened, and it was good in the sense that patients were seen and cared for. But we learned about telemedicine, and there was no double-blind control. It was like everybody was on it or they weren't on it. So we really don't know how effective it really was and whether patients liked it or not. It was just being done because we needed it, okay? And that is the big problem with telemedicine these days. We just don't have enough. All right. So then what happened was the home dialysis, the patients were already seen before COVID. And so with the public health emergency waivers, they now were at home. The doctors could be at home. It was a little bit more liberal. And I think now we're back to this panel here, which is what's written in by Congress. As far as the in-center dialysis patient, so nothing was done until the public health emergency waivers occurred. And for the first time, patients on hemodialysis were being seen by telemedicine. So the dialysis unit became a originating site. A lot of the patients don't have internet at home. They were finally able to do Zoom with their doctor, with any other doctor they needed to be seen, because the dialysis unit had the internet, they had the device, and so it was fine. They could be done. And the platform. So the dialysis unit realized that this is something moving forward. They established HIPAA compliant platforms. And so they have those in place right now. And it could. And then COVID was over. It ended May 11th in 2023. And then from there, everything's been on a continuing resolution. So far, Congress has not said, no, you can't do it anymore. And they just said, we'll just continue these public health emergency waivers. And that's what we've been doing. And in fact, when the government shut down in November, there was a period when we weren't sure if we were going to be reimbursed. And so a lot of people just stopped doing telehealth. But, you know, at the MFA, they say if they're already scheduled, you just continue. But then when Congress resumed again, they said, okay, we will pay everything that was done. And so now we're extended until, I think, January of 2026. So this is always a continuing resolution. So really don't know, okay? So that's the history of the telemedicine. All right. So that's the background. So how did I come about with this research? And so like Neil Seek is sort of my mentor on this. So he actually has been doing this telemedicine for quite a number of years. How many here know who he is? And okay, that's great. So you know, so he started out doing telemedicine for the Maritime Union. So people on ships, these are like cargo ships, and they have like a crew of like 25, 50 people. And if someone gets sick, it's not like they're on a cruise and there's a cruise doctor to see them. So they would actually call in to the emergency department, and somebody will pick up the phone and they would say, you know, what's the issue? And, you know, the captain on that boat would say, you know, this individual has a fever and has a sore throat, and, you know, there's a blood pressure cuff, there's a thermometer, there's antibiotics on board. And so they would take a look at the throat, you know, with the camera and send it over. And somebody in the ED will say, oh, that looks like a strep throat. Why don't you give them penicillin? And then, you know, call us back in a couple of days, you know. Or, you know, the person's having chest pain and, oh, I think this person's having an MRI. Why don't we, you know, move closer to land and we'll send a helicopter and pick that person up and, you know, airlift them to land. So that's what he was doing. I went to one of his sessions and we got involved in telemedicine. We wrote a grant and we got funded, and that's the CMMI grant, which we use to look at home peritoneal dialysis patients. So we recruited about 300 patients in Virginia, Maryland, and DC, and we did remote monitoring because they wouldn't let us do telemedicine the way I would like to do it, which is like the patient is at home and the doctor's in the dialysis unit. So we got some data from it, but shortly after that grant, they actually passed the bipartisan law. If you have money, it's always great. So CMI was that. Care First grant was used to look at telehealth at the Unity Clinic in the city. And so these are patients who have kidney disease or diabetes. And for them to come downtown to DC to be seen by an endocrinologist, a cardiologist, or a nephrologist was a one-day trip for them. So instead, we did telemedicine. They would show up to the Unity Clinic. the doctors would be here, and there was a presenter who would do like the vital signs. We actually had a stethoscope that we could hear the patient's chest, and a lot of devices that are attached to the computer, and we were able to conduct these visits. It was great. So the patients got care when they couldn't come to downtown, and so we had a paper out of that. And then my colleague Kevin has an NIH grant now looking at database to look at CMS claims for telemedicine versus non-telemedicine. And I think we're looking at hospitalization, length of stay. So all that information you can get from CMS claims. Those cost money. And of course, I don't usually raise money on my own, so I do the non-funding research, which is surveys, okay? So what I do is I construct a survey. I don't need anybody's permission because I'm making the survey. I go to the dialysis unit. I get approval from the dialysis unit's manager, and we are affiliated with DaVita, so I get permission from their research group, and I get IRB approval. I go to the 2 dialysis units that we are affiliated with, which is K Street and Southeast, and I just spend 2 days at each unit. I put down a survey in front of them. I give them a pen and I go, oh, please fill out this survey for me, with a big smile. And they sit there for 4 hours. So, they have time. So they fill it out. I pick it up and then I do it for the 3 shifts. And so in 2 days, I get 120 surveys completed in one time. So I got 240 in each unit and I'm done. Sometimes I miss a few people, but that's life. So besides the patients, you can survey the staff, you can survey, so the nurses, the dietitian, the social workers. So there's always somebody that you can ask a question or do an interview. Okay? So that's your resource. And the study methods that are available. So it's the surveys that I do. We talked about the Medicare claims data, but what we also have is the US renal data system. And does anybody know what that is? Show of hand. Okay. So every time a patient starts dialysis, the nephrologist fills out a form, 2728. It's like, what's the patient's name, how old they are, where they live, what's their race, have they seen a nephrologist before, were they getting, did they see a dietitian before, do they get treatment for their anemia, what's their cause of kidney failure, it's like 30, 40 questions, and got to submit it. And if you don't submit it, they come chasing after you. And so and every time somebody dies, you also fill out another form. So we know when people start dialysis, we know when they die. So this is the government when they want information because they're paying for the treatment, you got to deliver. So we have all this information. So is there a way to move this out here? Okay, so this is an example of some of the information you can get from the USRDS, United States Renal Data System. It's free, it's online. So they get all this information of new patients starting. So this is incident, it's by year. It takes 2 years for them to process the information. So I got this off of 2024. And so the last time you see is 2022. And you can see an incremental rise in the number of new patients starting dialysis. So we're up to somewhere about 130-ish thousand people with end-stage kidney disease. And interestingly, the line is flattening out. So part of that, we think, is COVID, like people didn't start or they just died. But also the introduction of SGLT2 and GLP-1s, because diabetes is the #1 cause for end-stage kidney disease in the United States. So if we can get that on the weight under control and blood sugar under control and blood pressure being the second cause of end-stage renal disease, this curve may be flattening out. So this is the prevalent number of patients on dialysis. So it's about 800,000. And so you can see there's about 500,000 on hemodialysis. There's about 250,000 with a kidney transplant, and a much smaller number on peritoneal dialysis, which is this line, and home dialysis. So the treatment is not as robust as the in-center, and that's why CMS is putting a carrot in front of the patient as well as the doctor, trying to increase the number of home treatments, because those patients cost less money than the in-center. They take better care of themselves. So for those who take care of patients in the hospital, you rarely get a patient on home hemo or peritoneal dialysis come in, whereas those that are in center, I mean, we get like 10 every day coming in for, volume overload, missing a treatment, because they're at home. They know that if they miss the treatment, they can make it up the next day. They don't go for days without treatment. So it is much better. So the carrot for the patient is, you can do telemedicine. You only have to go to the dialysis unit, once or twice a month instead of going, 12 times a month. And, the quality of life is a little bit better. For the doctors, you only have to write one note a month and you get almost the same reimbursement as the doctor who goes to hemodialysis and writes 4 notes. So it's not exactly, so we get like 3.5 notes instead of the 4 reimbursement, but it's pretty good. But you do carry the beeper. So my phone is always on. My nurse always knows how to find me. And, half the time I'm just saying, do this, do that. And it's taken care of at the home without the patient coming into the dialysis unit. So my goal is to keep them out of the hospital. Okay. But we like to see more of those numbers go up. And then they also have the information of how many people are actually on Medicare. So if you're interested in finances and reimbursement, you can see what's happening. So the trend is that fee-for-service Medicare is the bottom dark blue. The dual eligible, meaning Medicare, Medicaid, is this. But what's increasing is the Medicare Advantage group. So very interesting. Everything that happens with Medicare has always been experimented on the dialysis. So, for example, like the accountable care organizations that we're in. So we call it the bundle. So in dialysis, at one point, every time you did a dialysis, you would send in an invoice to CMS that we did a dialysis. You gave them, the patient, some medicine. You would bill Medicare for the medications. You drew blood and you did a blood test, you would bill them. So they were getting like hundreds of bills, and they, of course, would pay, but they got tired of processing with paper. So after a couple of years, they realized that each dialysis patient costs a certain amount of money, some more, some less, but we know what the average. So they said at one point, okay, now we're going to just pay you like the middle amount of money, and we're going to just pay you that amount, and it's your job to take care of the patient. If you take good care of them and you make a profit, it's yours to keep. If the patient is really sick and you don't take good care of them and you lose money, that's your problem. Just tells you you have to do a better job. So they sort of keep you in the middle lane. And so that's how they know how much everything costs. And so it's the bundle. So now we have the accountable care organization. They say, here's X amount of money, and you're responsible for these lives. And if you do a good job and they don't get sick, they don't get hospitalized, you keep the money. If you don't do a good job and they get readmitted to the hospital all the time, you lose money, then you need to come up with a better plan to take care of the patient. Okay. So we have a small group that they experiment on, and then they bring it out to the outside. So the bundle in the dialysis unit is the ACO. Medicare Advantage is sort of along that line. They go, we know how much it costs to take care of these patients. Here's the money. So now Medicare Advantage, they go, oh, come and join us. We'll get you transportation. We'll give you meals. We'll give you physical therapy. They attract all these patients. So Medicare is giving them this money up front. So they have all this money. And then whether they pay up and do what's right for the patient, that's another story. but they have the money upfront. So that's the big change that's happening, and that's the lavender color Medicare owns. All right. So if you're interested in finances, the information is here. Okay. So that was the results, meaning we know that telemedicine can work. There are a couple of papers that are coming out by Kevin Erickson about the Medicare cost, and because he's been going through, he actually purchased the Medicare claim, so he's been going through it with his colleagues. So now is the discussion. So what are the good things and the bad things about telehealth and the in-center? So the good things about it is the doctors don't have to travel to the dialysis unit, because there are private practice nephrologists who cover like 6 or 7 dialysis units, and they spend all day going to the first shift and see everybody, come around the second shift and see everybody, come around the third shift, and they spend a lot of time in the car and traveling around. But with telehealth, if they sit in one place and there's someone who can bring the camera in front of the patient, they actually can see a lot more patients without having to travel. The patients who don't have internet service will have it because the unit has it. And the patients actually, through survey, have found that they really like it. I mean, they're okay with telemedicine. There's nothing wrong with, the doctor coming to see them, but they feel connected with the doctor, and they sit next to each other. Everybody knows everyone else's business. I mean, you can put earphones on and you can sort of keep the conversation one way. We really don't examine the patients in front of everybody, in the dialysis unit. If we have to do a detailed exam, we actually take them, to an exam room in the back, but otherwise it's usually looking at their legs to make sure they don't have any leg swelling, and we ask them, do they have any shortness of breath? So the bad thing about telehealth is that we can't do a physical exam, and there's lack of privacy, and there's concern about internet security. But I'm very hopeful that in the future that the phones will be able to have devices where you can just put it over your heart, and the doctors will be able to hear heart sounds, and we can already do EKGs on the phone. So I think these things are coming. It just takes a little bit more innovation and technology to get that going. And then for the home dialysis patient, it saves the patient a trip to the dialysis unit. And in some areas, people have to travel 2 to 3 hours to get to a dialysis unit. So for example, pediatric nephrology, there aren't too many nephrologists, and they cover a wide, like in a state in the middle of the country, there's the University of X state, and there's that pediatric nephrologist is the center, and everybody from the state has to go there to be seen, because there aren't nephrologists, pediatric nephrologists in the community. The other advantage is that we always want to know what the patient's home is like, and our nurse goes there and does a visit at the beginning and once a year, but otherwise we don't know what goes on at the home. But with telemedicine, sometimes you can see what's in the back. You can see what they're eating. You can see how clean their house is, the clutter and all that stuff. And I mentioned the pediatric patients, that saves the family a lot of time, because they have to go with the patient to the unit. Of course, the lack of physical exam, the lack of privacy, especially for a teenager, they want to talk, without the parent listening, and so it's a little bit more difficult. So the limitation of this study is that everything that is in this paper is observational. There was never an intervention where we said, okay, we're going to put X number of people on telemedicine and X not on it, and let's compare the two. That never was done. So everything is observation. People who elect to do telemedicine, it's biased. They're usually the people who have access to internet, they have access to device. This thing is not cheap. This is about $1,000 if you're going to buy it. So who can afford? Not everybody can afford this. All right. There's rural versus urban, and of course, there's social determinants of health. It's about internet access, and there are lots of things that the federal government is doing to put money into getting internet. So it's laying down the wires. Okay, so here's another question. What are the outcomes or recommendations that could apply to your own practice, your education, your administration, and or further research based on the evidence presented?
Have people tried to use, like, I mean, they're kind of captive audiences, like you were saying with your survey. Have people tried to use this as like, just do telehealth for other clinics? So like, you know that your patient is doing dialysis, they're sitting there, and you do their like GP or cardiologist, or like, are people trying to use other specialties in that clinic?
Well, you know, there are, so the way telehealth was done during COVID in the in-center, the dietitian, bless his or her heart, would wear the mask, get all gowned up, and wield a laptop in front of the patient, and they did the telehealth with the nephrologist. To get a telehealth with a primary care doctor or specialist would require a little bit more coordination. But if the patient had the appointment and somebody at the dialysis would be willing to bring the computer in front of the patient, I'm sure it could be done. That would be a good study, you know, to say certain patients don't go see their primary care doctor because of transportation issues. Let's set up primary care visits or endocrine visits for like the next month, you know, every 2 months, every 3 months, and look at people's blood sugar, blood pressure, you know, whatever, at the end of the year. So that is something that can be done.
I practice in a pediatric emergency department, and we get a lot of transports in from all over the kind of DMV. And there's a good chunk of those kids that end up getting a blessing and then going right back home because they needed someone with like pediatric knowledge. They didn't need any specific intervention. So it could be really interesting to kind of to see if like telehealth consultation for those folks could prevent expensive ambulance transports from multi-state, or having our transport team go and get them. And the same as like I'm sure we're going to happen this winter, but there's a boarding crisis, and the number of pediatric beds at smaller community hospitals has really diminished. So there are EDs that are, you know, out in Calvert or wherever, that have to take care of kids for longer than they are really comfortable with. Like they would like it to be like, hello, come get them. And we're there within an hour, and that's not happening anymore.
Yeah.
So the ability to have like a PICU consultation where you could be like, oh, I think you could actually go up on that high flow, or I would put them on BiPAP. Did you try ketamine sedation or whatever for that? Could be really cool. And maybe we could even discharge some of those kids instead of having them come all the way here.
Okay, so what you're saying is like a specialist consulting like a primary care doctor to help them care for the patient in their local setting as opposed to transferring them.
Yeah, or like local emergency departments, yeah.
Oh, I was also thinking of like sending kids home that you normally would not send because they're sort of on the fence, and then just call in every single day and sort of take a look at them, because just seeing what they look like in their home environment, you can tell whether they're compensating or if they're going to get better. And then you can also see the home environment, because I'm sure you're worried about child abuse and, you know, the relationship with family. You can pick that up with telemedicine, and sometimes you won't see that in the doctor's office because only one parent comes and the other one's not there. But when you do telemedicine and you have the whole family behind, the siblings are screaming in the background, and you see the parents are also, you know, coming in and out. So there's a lot you can learn. Yeah. So that's called teleconsult, the one you were talking about where a primary care doctor would call in and ask for help. Yeah. So that system is actually working. Now, can I say this or not? Well, the paper will probably be published. So at the VA, they have a hub and spoke system where they have nephrologists at 2 or 3 hubs, and they link to centers that are sort of in out of state in the rural areas, and they do consults taking care of these patients. And it's interesting, what they wanted to do was to put more of these patients on SGLT2 and GLP-1s and RAS inhibitors, trying to control blood pressure, reduce proteinuria, and control the decline in kidney function. And it seems to be working because, the VA system is just one system, so it's easy, and they all have the same electronic health record, and the docs they can prescribe, so it's not like, oh, I'm in a different state and I can't prescribe. So, I think a system like that can actually work. So, yeah, people are thinking outside of the box, and
yeah. So there's a policy question you just touched on there, I think is worth exploring further, and that is the interstate use of telehealth is very tricky. The VA is its own, as you say, it's its own unique system where a practitioner or a licensed practitioner within the VA system can treat veterans in other states.
Anywhere in the United States.
Not so Virginia into Maryland and vice versa. And so part of the research question, and really it's a policy question for the feds one of these days, is why is that silliness the case?
Because feds don't have interjurisdictional authority over health professional licensing. It's a state by state decision. And health professional licensing boards, there's a number of factors related to it, the least of which is who has the authority to oversee professional practice and deal with disciplinary actions when the patient is harmed. And that is often the leading thing that makes the decision for health professional boards. So if the patient is in Maryland and the provider is in California and the patient is harmed in Maryland, the Maryland does not have the authority to discipline the provider in California. And the patient's recourse is limited because the patient would have to appeal to authorities in Maryland for recourse. Their courts would be in Maryland, et cetera, but the offending provider would be all the way in California. And so then when the patient would take their actions to California, the provider has not committed a crime in California or harmed them in California. So these are all of the things that make it so complex. Like for most people looking at it, they're like, but people just need access to care, et cetera, et cetera. But when you start looking at it from patient protection perspectives, it gets a little bit nuanced in terms of what tort reform and all of those things make it very, very nuanced and complicated. What has in effect happened is most of these telehealth companies that you now see that treat obesity with GLP-1s over the internet and your hair loss and and other things that they find that a certain segment of the population has zero interest in establishing continuity relationship. They just want the meds. They pay for those providers to get licensed in all of those places. So they can take care of all of those people using telehealth and telemedicine. They have no qualms about paying your licensing fees so that you can provide that care. But it is really a matter of if the patient is harmed, will they have the ability to have due process in courts? Yep.
We have that here at primary care, so all 3 states they pay.
Yep.
Right, so we
Kaiser does as well.
DC, Maryland, and Virginia.
Yep, Kaiser does as well for in the Mid-Atlantic region, in the North Pacific region, in Kentuckiana. Those hospitals who are border states all tend to pay for their providers to be licensed in those jurisdictions.
That's great.
But that
Bringing that up.
that end up being.
State license reciprocity, because every state has different qualifications.
Yeah, so state licensure reciprocity faces some of those same challenges. And also sometimes the criteria for licensure can be variable. Most states are now offering reciprocity through compacts. But the way that the compacts are designed are a little bit limiting. The medical licensure compact essentially offers no benefit. You still have to pay everybody the fees. And it allegedly cuts down on some of the processing time, but I find that the administrative burden is just as high. The nursing compact.
Recent experience, ongoing experience, it's useless.
Yeah.
Yeah,
That-
I have to apply to Maryland every 2 years.
Yeah. The nursing compact is a little bit more efficient, in that it does reduce some of the administrative burden. But and those are the two largest. There's one for pharmacy and physical therapy. And each state has to opt into it, and most of them do it side by side comparison. And again, it gets down to where does disciplinary action get adjudicated, and that's where most states makes decisions around participating.
All right, so we'll move on. So in summary, telemedicine started as experiments. Telemedicine was limited to rural areas and originating and remote or distant sites. They were restricted. But the Bipartisan Budget Act of 2018 sort of opened opportunities for home dialysis patients to perform telemedicine. And then COVID, there was the public health emergency waivers that relaxed many of the CMS regulations. And now telemedicine is here to stay. I don't think it can go away because patients are asking for it. And I actually have one clinic a week and two where they have to come in, and the patients still love it. And I think it's going to keep on going. So hopefully Congress will make it a permanent thing. Clearly there's abuse in the system, and that's what they're trying to figure out, if there is. So how might the study's finding affect healthcare delivery as a systems level beyond individual patients or clinic? So looking at a bigger picture.
Thinking about unique places you can see patients is, I think, one of the big ones. Like, you're allowed now to see patients for telehealth in dialysis clinics, like maybe like schools or
The originating sites.
Yeah, make it like it works. So someone could just take 20 minutes to go into a room and do a telemedicine instead of taking a couple of hours off to travel to the doctor's office, wait to be seen, and then be seen and go back. Usually the excuse note we write is for, like 2 or 3 hours. So it could be very productive. So I think there is definitely room for changes for the originating site, the remote sites, and how we conduct telemedicine.
I think one of the biggest things for me when we were looking at some of the, like in the first 6 months of the telehealth waivers during COVID, was the lack of health outcome data. A lot of it was focused on provider satisfaction and patient satisfaction, but not actual health outcomes as the endpoint. With some of the organizations that were looking to sustain the waiver, especially in under-resourced communities, their interest was preserving the telephonic only aspect of telehealth and not having visual capabilities because of issues with broadband and internet limitations. Of course, your study isn't designed that way because you're talking about using the full audiovisual capabilities in your visits. But what are your thoughts on that and research studies that look at the different types of modalities that fell under telemedicine during the public health emergency?
So during the public health, Medicare reimbursed both telephonic as well as the video.
Yep.
But now they seem to push more. If you could do video, it would be better. And only if they can't do the video that you'll do the telephonic, but they're still reimbursing for it.
Yeah.
And I guess there's a older group of patients who are still not facile with videos, and they're gonna age out, and so, you know, the new generation will become the old generation. And I think it won't be a problem to do the video, and I think that technology will improve. It'll be much easier to just get the video. And again, you know, there'll be more technology on the phone that we can actually listen to heart sounds and breath sounds. Yeah, I mean, I have patients showing the camera of their legs, and I tell them to push down, and I can see pedal edema. You know, that's my gauge for volume status. It works, yeah. So I think there's a lot more that could be done in telemedicine. So with technology, I am actually for AI because there's so much data that's coming in from remote monitoring. There's no way that someone could sit for 2 to 3 hours each day. Like, for example, in my peritoneal dialysis, we get blood pressure readings every day, and we see how they're doing on the cycler to do the exchanges, and it's just too much. There's no way, and I have 20 patients, so that means that's at least 5 minutes. Just open the chart. 20 patients, that's 100 minutes. That's like 2 hours of the nurse's time to look, and it's not always a problem. So if there's a way that we could, you know, say that this is normal for the individual, and anytime there's an outlier, you know, flag it, and then the nurse will look at it. So it's good in that sense. I know in pathology, they're using AI to sort of look at the morphology of a kidney biopsy, and then sort of get the information and then flag things for the pathologist to look at. Because to look at a kidney biopsy, there's a lot to look at, and it takes hours. So it's all about pattern recognition is what that is. We've been looking at wearable artificial dialyzers for the longest time. It hasn't materialized. There's problems with the system. But the latest thing is gene-edited pig kidneys for xenotransplant. And we've had a couple of those in the United States, and they seem to be quite successful. So there's technology in the kidney space, and I just want to let you know that these are my colleagues, and they're all interested in doing research in this area. So if you have any interest in the dialysis population, transplant population, chronic kidney disease, we're available, to work with you. So thank you so much.
Thank you, everyone. And I know it's our last one before the holidays, so I want to say happy holiday, happy new year, and I hope to see everybody next year. In January.
We're moving to the other.
Yeah, we're gonna move to
602.
602. But please, if you didn't sign up, please sign in. I'm working on getting PMEs for this, so it's in process.